Okay, well, welcome everyone. We're the Association for the Chronically Mentally Ill, an organization that works to advocate for more resources for the people with serious mental illness. And tonight, we are very fortunate. Um, well, let's go over some rules, but we're going to learn about the impact of substance use on the developing adolescent brain by Dr. Sean Kelly. We're very fortunate because Dr. Kelly, there are two ways to study about disorders, mental illness, what's going on in the brain. One path is through psychiatry, and another path is through medicine. And Dr. Kelly um, he's an MD with a background in pediatrics and brain science, and he is currently at Boston Children's Hospital, a Harvard connection, where he is doing a fellowship to further that education because they're the experts on addiction. Again, all the information presented here tonight, it's not medical advice, it's education. Please mute your lines, submit your questions in chat. We'll ask them at appropriate times. If you want a certificate, send it, and we'll have this again at the end. Here is the ACME Board of Directors. And with that, I think I'll turn it over to Dr. Kelly to talk about and teach us all about the brain and brain research. I can't tell you how thrilled we are to learn about the research being done, which we think will come up with cures, if not cures, really good treatments instead of the same old treatments that have been used for 40, 50 years. And with that, let me turn it over. Again, Dr. Kelly.
Great. Well, thank you everybody for being here. I really appreciate it. And I thank you for the nice introduction. And it's great. I hope that we can everybody get a lot out of this session, and I'd like you to guide me if we are going off track in a different way, and we can leave lots of time for a discussion where we can take it down pathways that aren't necessarily included in my slides. So we'll kind of get through those at our pace. Yes, and so, yeah, I'm Dr. Sean Kelly. I'm a pediatrician from Canada who's in Boston these days, learning at the Boston Children's Hospital, associated at the Harvard Medical School as a clinical fellow there. And right now, the bulk of the adolescent addiction medicine policy comes out of the place that I am lucky enough to work. And it's a wonderful place to learn, and they're doing very interesting things, and we can talk lots about that. But first, let's get a little bit about the interesting stuff that I'm getting to learn too. And here we have sort of the subject of what we're going to discuss today, and we have adolescence. And what we have is pictures of wild hair, questionable decision-making, rebellion, self-expression, and even some substance use. And this is our very vulnerable population, and where a lot of our addiction starts. And we'd like to figure out why that is. And to get to why that is, we have to think about inside our skulls, and we have to think about a long time before this. So can I have the next slide, please? There. So I like to start this off by talking about how the brain matures a little bit. And there's three different ways to talk about how the brain matures that is pretty useful to the context. So I think the first way to talk about is the gross anatomy of our brain. I think that it looks like we've got probably lots of parents or people familiar with, infants and such, and their heads are pretty small, and their brains are not fully formed when they come out. But in terms of a gross anatomic structure, there's not a lot of progress that happens after 10 years of age. So an infant comes out, their brain, on an MRI looks smaller, but well-shaped, well-formed, and it gets a little bit bigger as they get to 10 years of age. But by then, all of the gross structures are there. So what we could see with our eyes, if we could look through skulls, I suppose, wouldn't change much from that point on. Sometimes I like to get lost in these really extended metaphors that only sort of work. And the one I like to do for here is if our brains are a library for all of the tasks that we can do, all of the facts we're going to learn, and all of the I don't know, things we're going to master. The structure of our brain that we're talking about that's complete by 10 years of age is really the physical part of the library. It's the walls, it's the stacks, it's the shelves upon which we're going to put our books full of information. And so, from that perspective, that's all done and in the bag by 10 or 12. Good. Next slide, please. Okay. The next level that I think it's important to think about the brain's development is on a cellular level or at the level of the tissues. And the brain cells that we're interested in are the neurons, and this is what we have on these slides here. Um, at birth, what we have is a slide with several neurons on it. I counted them. There's 14. And what we see is the three important parts of the neuron. We have the cell body, which is in the middle. We have the dendrites, which are the small root-looking things off the end. And then we have the axon, which is the long stick that comes off in one direction from the body of the cell. Perfect. Thank you. This is great. So when we're born, we actually have almost all of the neurons that we're going to have for the rest of our lives. We gain a few more, but most of the ones that we need are where they should be. They have been developed and migrated to the place where they're needed. Okay. And this is what we talk about when we're thinking about gray matter. Okay. That's the stuff that's dense with neurons. Okay. So, but at birth, we don't know everything that we're going to need to know for the rest of our lives. And where we see the big difference isn't in terms of gaining numbers of neurons, though there is a small amount. What we see is connections between neurons. And so in the second slide, when we have a 6-year-old child, what we have here is I counted this one too, and there's only 16 neurons in this slide. Okay. So it's not like there's a vast number more neurons, but what we can see is there's an incredibly more dense level and number of connections between those. So we have the axons that are overlapping with the dendrites that are branching out even more, like the root system has really taken hold. And I find it useful to think about this is this is the phase where we're trying to fill up those stacks in the library with information, and we're doing it very rapidly. So what we need is a lot of plasticity and a lot of communication between the neurons, an ability to make new connections, learn new things. And sometimes, if we think about a 6-year-old child, it's an incredible period in their development. Like I have 2 5-year-old children, so their brains probably look like this or something similar most of the time. And what they're doing at this time is, they're learning to read. They might be learning a second language. Their physical attributes are getting incredible. If they were children who weren't mine, they'd probably be learning a musical instrument or how to throw a curveball or something of that effect during this phase where there's an incredible amount of skills that can be gained. So what we have is the setup, the cellular setup to allow that learning to occur is this density and overlap of the dendrites and axons more than just the neurons themselves. As we mature on into the 14-year-old brain, what we see is there's a clear sort of pruning that's happened. We were talking about roots, and what we have now, or branches, I guess would be a better metaphor. Again, see, I like to mix them up a bit. And what we see is that we have a reduction in the overall number of connections. But what has happened is that the important and very relevant connections are maintained, and these things are permanent now. Okay, so we've lost some of the extraneous details, but we've kept what's really important, and we're trying to get this learning to be very solidified. So what we have is a very controlled dying back of parts of our neurons in our brain. This is a very delicate process called apoptosis that has to be uh, well controlled. So we're talking about programmed cell death. And when we're using toxins in our brains during this period, we're vulnerable to uncontrolled cell death and inappropriate cell death, and not the kind that we want. So during this pruning phase, it's a nice way to think about not wanting to be bringing in any extraneous or damaging chemicals into the picture. Could I have the next slide, please? Okay. So these brains here they're composites. It's a whole bunch of different brains through a PET scanner that has been overlaid on top of each other just for purposes of illustrating the point here. And I hope I'm not losing you. I hope I'm not getting too technical. Is everybody we're okay here? Yeah.
I think it's great. I think it gives that baseline around why it's so important that we keep drugs of all forms and influences away from our adolescent
Absolutely.
members of the
Fantastic.
society.
Great, great. Okay. So the last way that I like to think about brain maturation, or that we like to think about this and present it to folks, is a process called myelination. Okay. So when we have all these, we've had this pruning go on, and so we have what we believe are the important connections sort of isolated and maybe highlighted within our brain. The process of myelination is the reinforcing of those important connections. It's insulating the wires that really matter. That's a good way to look at it. This is a process that is slow. It is delicate, and it happens over the course. We believe that it finishes happening around 25 years of age. Okay, this isn't a change in the number of neurons. What it is those wires between the neurons are getting wrapped with a substance called myelin that is largely made of fat. And this happens in a really planned and deliberate way within our brains. What we can see is that when we look over at the 5-year-old brain on the top left part of the sliding scale here, the blue regions are the places where we see a lot of myelin. Okay. And so I think, what we see is a progression of myelin from the back. This is the right at the line. If we're looking at the brains underneath, that's a brain from the top, like the nose would be touching the line, essentially. And so what we see is that there is myelin at the back. Okay, that myelin sort of inches forward and it covers the regions at the back of the brain. And then when we're 20 years of age, we have a lot of myelin, but there is some gaps in this area here that would correspond to what we call the prefrontal cortex. Okay, that's going to be rather important. So the job isn't done at 20, and there's a particular region that is still vulnerable and not yet highlighted and made most efficient by this insulating process. Could I? Yeah, exactly. Yes, perfect. Can I have the next slide, please? Okay, great. And so when we think of back to front, as the maturation happens, we can look at these different regions. And so this is the cerebellum, which I believe is Latin, probably, or Greek. I think it's Latin for little brain. And it's this region sort of behind your ear at the top of your spine. And it is responsible for a lot of autonomic functions, sort of blood pressure and things like that, but also for coordination and getting our limbs right in space and getting our balance right. And so as this begins to be myelinated, can I have the next slide, please? The process of walking begins. So we need a cerebellum that works effectively and can function and make the right muscles contract in response to the right stimulus so that we can learn to walk. Because what is walking if it's not falling and catching yourself repeatedly? Okay. The next slide, please. So this part of the brain, as we move a little bit forward, we're kind of moving under what we saw last time, but it's still the same progression forward. In the amygdala, this is the portion of the brain that lights up when a 2-year-old comes into my office and they're afraid of getting a shot. This is sort of our emotional regulation region, and this is what fires when we're very upset. Can I have the next slide, please? When kids have a well-myelinated amygdala, we see this as tantrum control. What we see is a bit of emotional regulation that happens, and we see kids who can calm themselves down periodically, and so this is sort of happening as we're getting towards school age, okay? Just sort of preschool age, perhaps we'll say, kindergarten through grades 1 and 2, and that's where we really expect emotional regulation from our kids. Can I have the next slide, please? This place, as we move just a little bit far forward, but we've changed regions pretty importantly. What we have here is the nucleus accumbens. This is the region of our brain largely associated with what we call the reward pathway. It's one of the regions that are really associated with the reward pathway. The reward pathway is what motivates us. Can I have the next slide, please? This is one example of a reward that as kids are getting their nucleus accumbens online would be they want to please. They want to please their teachers. They want to please their parents. But the motivations that light up our nucleus accumbens are quite varied, from a good meal to sex to, just achievement of any kind, or there's tons of things that we perceive as reward that make this area light up. But an A+ on a spelling test, I don't know what that's like. So I imagine it might cause the nucleus accumbens to light up. And then could I have the next slide, please? And so then finally, the prefrontal cortex is the last thing in this sequence that gets myelinated. And can I have the next slide, please? The prefrontal cortex is responsible for a remarkable number of important things that this young woman is not doing entirely. She's trying to do a good job of it, but she's not. So, this region, the prefrontal cortex, we think of as responsible for attention, for organization, for impulse control, risk assessment, error detection, and motivation. Okay. So, this last piece that is not fully online until we're probably 25 years of age, and the big part of that I think is really important would be impulse control and risk assessment. Those are probably the most germane to the rest of our conversation. Could we have the next slide forward, please? So, one way to think of adolescence is it's the time of our lives. It's the age where we have a significant gap between our motivation, okay, and our desire for rewards and our ability to make really good sound decisions. So the metaphor that we like here is it's all gas and no brakes during adolescence. And what we have is the drive to seek that reward. That part of our brain works really well. It actually works better than it's ever going to work in the rest of our lives. And that's probably important from an evolutionary standpoint. But unfortunately, our good decision making has not fully come online yet. And I think this is a nice way to understand adolescence. It's truly a brain maturity thing, and I imagine there's some parents of adolescents in the group, and this may be a nice thing. It's like, why did they keep on doing that even though they knew it was the wrong thing? It's just unfortunately they don't have the physiologic ability to change some of their thinking, and so that leads to some crazy actions. Could I have the next slide, please? Okay, this is a wonderful slide. So what this is looking at is within the nucleus accumbens, probably of rats. I believe it's rats. We're looking at no, you know what? It's no, it's not. This is human children. Pardon me. Sorry, guys. But what we're looking at here is dopamine surge within the nucleus accumbens in response to offered rewards. So what that means is we're looking at how much chemical and how much dopamine, that's the language that the nucleus accumbens and its connections speak, is released in a brain in relation to a stimulus. And it actually happens most before the stimulus rather than after. If we look at the blue line, that shows us the younger children's brains. And my favorite example for this is I come from a pediatrics world, and it's the best way to get a little kid to do anything that you'd like is to offer them a sticker, and they say okay, and they'll do anything, and they could be very afraid one moment, and you offer the sticker, and they have a great feeling. They get their reward pathway lights right up, the connections to the rest of their brain. They get a soothing sensation. They really want this, and they do what you want for the sticker. Um, and then what we see is actually, if you look at the black line, that's the adolescent response to a trivial reward or a small reward. As you see, it actually goes down from baseline. So if I try the sticker trick on a kid who's just a little too old, it really blows up in my face. They really, that's when you get the eye roll and the arms crossed and they sit across from you like you're, yeah, they they make you realize you've made a mistake in your actions when you do that. However, when we move over to when it's a perceived large reward, what we see is that adolescents in this black line blast way up, way past adults, way past little kids. So this is what we see is that adolescents are primed. They are literally physiologically primed for large risk and big risk taking. This is probably evolutionarily important, as I was saying. Eventually we wanted the kids to move out of our cave and get their own cave somewhere, and it would be important for that sometime in this point of their life for them to seek out their own hole, their own pathway, and find these big rewards. So it probably means something, but in our brains, in our society these days, it leads to some a different set of consequences. Could I have the next slide, please? Okay. So yeah, this little spot here where all the arrows are sort of pointing to, that is the nucleus accumbens, okay? And the other thing that can really affect our nucleus accumbens and make it light up and give us that big reward sensation is drugs. And we think of the ones that we think of as addictive really operate in this place. Addictive drugs, and we can play with that term for a little while if you guys like. Some people say, is marijuana an addictive drug? And there's lots of different ways to think about that. But what we can say is that these substances all enhance our dopamine secretion from the nucleus accumbens. They light up or turn on our reward pathway in a very big way. They all do it by slightly different mechanisms, but the end result is the same. The nucleus accumbens secretes dopamine along this arrow, and it ends up in our prefrontal cortex. Okay, so these drugs make us feel good. Okay, and adolescents get an even bigger kick, an even bigger charge, dopamine, bigger reward, bigger payoff into their prefrontal cortex. So that area that was responsible for risk assessment, for impulse control, is getting soothed in a really big way when we deliver it drugs. Okay, could I have the next slide, please? I think that's, yeah, that's a good way to say what I said in, you know, 75 fewer words. Next slide, please. Okay, so when we think about why do I need to be an adolescent specialist in addiction medicine or drug dependent medicine? So the reason is because most drug use starts in adolescence, as you see. And so when we look at all of the drug use, it's, if we get to 25, there's a really low likelihood that people are going to initiate and continue drug use with any significant level. So that's, but what we see is that the biggest bars, the three biggest bars in the middle, are between 14 and 20. And that's where we see a lot of the bulk of substance use begins here. And the bulk of substance use that becomes substance use disorder or addiction happens there too. Not to ignore the 12 and 13-year-olds. That's a really important group too, because we know for a fact that the earlier that we start abusing any substance, the more likely we are to develop a substance use disorder. That data has been proven very well with alcohol use, with cannabis use, with cocaine use, with opiate use, and with benzodiazepine use. So it's truly, all of these bars are important, but we do see the bulk happens in this teenage period. Yep. Yeah. And so you know, why don't we go to the next slide and then we'll take a pause and do a couple of questions, I think. Okay. Yeah. So I think, again, this is, I should just go ahead one slide and I'll save myself some breath because it seems like there's an efficient way to say what I try to say and it comes after. But so why don't we just have a look at a couple of the questions? I just saw the last one pop up.
Yes. What about pornography? And I have some other that came in as text.
Yeah. Yeah. So in terms of the data around, like, for sure these days, the time of initiation of pornography use is getting earlier and earlier, just with the access to pornography, pardon me, that kids have thanks to the internet. It's incredible. It's shifted drastically. You know, it used to be in the, like, sort of mid to late teens, or 15 and up, and now it's much younger than that. It's 9 or 10 years old where a bulk of kids are seeing their first pornographic images. When we think about you know, use disorders and addiction as a great thing, we sort of think of, there's the substance and there's the behavioral addictions, and pornography we think of more as a behavioral addiction. However, these principles are all applicable to all. And so the behavioral ones we think about would be pornography and or sex addiction, gambling, and sometimes disordered eating can fall in there, and video games. That's a big area that falls into the behavioral. Yes, it absolutely is rewards. Those are all the things that really they punch the reward pathway as well. In that picture of the reward pathway, there's sort of two entry points. The nucleus accumbens is probably the most important, but the ventral tegmental area, which is the sort of the, I don't know, the back door, I guess, is also a very important part. It's actually more associated with our deeper brain, like our old reptilian brain. I don't know if you've ever heard that statement before. But it's so, and sometimes things like Gambling is kind of all over the map and all over the reward pathway. But we think things like disordered eating and maybe sex come from that ventral tegmental area, and that's where the onset of the dopamine pathways activation is.
Okay, two other questions. One is, you talked about the myelin progressing and covering the brain as you mature from the baby brain to the adult brain. If you are starved or don't have enough food, does that impact the myelin coverage? Does it become inadequate, thinner, delayed?
Yeah. So, severe malnutrition absolutely will cause significant aberrations to your brain development. The severity, that being said, brain development is one of these really protected things in our body. We will almost let everything else go in order to maintain our proper brain development, which is, evolutionarily sound. But, from a nutrition standpoint, we see skin problems, we see bone
Mhm.
problems, we see tons of things, but most of the time, especially with the nutritional deficiencies that we see in North America, we can still see relative preserved brain development. I think one of the important things I was talking about when I was talking about it's made of fat. One of the things that we think about with THC, or the active component in marijuana, is that it is really fat soluble, and so what that
Mhm.
means is it deposits in the fatty tissues of our brain. So if we are taking a bath, an internal bath in THC, as we're laying down this very important first layers of myelin and these important layers of our brain, it's probably not, and it's not a good situation for optimal brain development and optimal coming online of these important later features that could be competing with, like, we're trying to learn how to control our impulses,
Mhm.
and if we're taking baths in THC, perhaps we're not going to learn how to do that task particularly well. Our motivation may not be as strong, and that actually plays out in the data that's coming a little further down.
Okay, we have one. What mechanism is active in the bully to bullied on social media issues?
Pardon me, say that one more time, please.
What mechanism is active in when I think you see bullying going on in
Oh,
social media?
hmm. That's a good question. That's a great question. We know that when we think about likes on social media, thumbs up and that sort of thing, views, and
Mhm.
that is a potent stimulus at the nucleus accumbens, and that is a very potent dopamine drip that we can get. Even checking your email for us adults is it's similar, but it's at a very different scale for the young brain. What mechanism is involved in bullying? I don't know that I have a great answer for that. Maybe competition for that dopamine hit.
Mhm.
I'm getting into the area of conjecture, but my
Mhm.
my theory would be that um, there's lots of reasons why online bullying. I think when you don't have to see the face that a hurt person makes in front of you, it's a lot easier to bully them and push a button to do that. But
Mhm.
that's I think.
That
Um,
distance, so
yeah.
you're not really experience. It's like even violence. Easier to do something at a distance than to have hand on hand. Hand on body.
Absolutely.
Yeah.
Absolutely. Our brains develop it by, one of the reasons that we're worried about young kids and screen time is because that we know that while kids can learn some interesting things about sorting shapes on their iPad, it's face to face, and it's the emotional connection, and it's both sides of our brain lighting up when a parent or another sibling is interacting with a developing young person. That's where the magic happens, and it's we're built to look at each other's faces, and so I think, yeah,
One
when we
other question. So we talk a lot about, and tell me if you want this question to come later. When do you start to question the behavior and say, this is just a adolescent with the brain not developed, or this is really triggering alarming flags that I should do something, say something, go to a specialist?
okay. Do something, say something. I think all the time. I think that in terms of behavior that's concerning, I think that the best situation for an adolescent to be developing in is one where they're adolescents have a need for privacy and they want to push off. It's an important sort of like Ericksonian in terms of psychological development. They need to do this in order to find some independence. However, if we're able to have or attempt to have conversations about them that are a little bit difficult to initiate, but really great when they're done, about making bad decisions about driving, about using substances, alcohol, marijuana, nicotine, probably the most relevant early conversation to have these days. So what I would say is that to say something is always a good time. If we can have these conversations and we can have that open, honest dialogue, that's a wonderful, wonderful thing. Open and honest dialogue is a bit that's a lot to ask, but if we try, then the possibility that it might happen may be very good. I think that when we're talking about when is it time to seek expertise out, I think at the first sign of concern, but what we use, like when we talk about use disorder or substance use disorder, be it cannabis, alcohol, opioid, the real measure of when it's a problem is when things are going wrong. Is we have one of the criteria is continued use despite interpersonal problems. So, if you're telling your kid, I want you to stop using, this is really upsetting me, and they keep using, they're most of the way to the criteria for a use disorder.
Mm.
Okay, right there and then, if it's affecting their personal relationships, if they seem to be doing it more frequently, if they're making bad decisions, if there's danger, if there's injury, these are the things that say that there is a problem. But the earlier, like with anything, the earlier the better. So if concern is raised, I think it's a great time to get checked out.
Now, you can say if you want this next question later, but can you discuss schizophrenia, psychosis induced by drug use or any other behaviors or maybe traumas?
That's going to come. So let's
Okay.
we'll hold off on that. But that's
So
great.
do you want to go to the next slide?
Yes, please. Okay. This is one of those extended metaphors that kind of works. What we think of is this house that is partially built. We have the frame up, and this house is particularly vulnerable to weather. If there was a significant storm, we'd be pumping out the basement of a significant amount of water. If there was drywall or sheetrock up, that would have to be all removed. If this water, continues to fall, we're going to have warped boards. We're going to have to rip down the plywood and change out the studs here. But once the roof is intact, this house can handle a little bit of weather. And so the metaphor here is that this developing brain, until we're 25 and we have that brain fully functional, that brain can handle a little bit of rain. It can't handle a hurricane. That's like a binge. That's going to be damaging no matter what. But a little bit of rain, a little bit of substance use when we're in our 30s, no big deal. However, both gentle weather, any weather, and a hurricane are really damaging to this house that's in its semi-constructed phase. Next slide, please. So this is the exciting molecule of the day. This is THC. And THC is in the purple, and then anandamide is in the teal. These two structures are important. So THC, I think we've all heard of, but maybe anandamide we haven't. And so, but the purpose of this slide, how they're lined up like this, is that these two things are essentially keys for the same lock within our brain. We named the lock that these open the cannabinoid receptor because we only discovered it after we had discovered marijuana and the marijuana effects on the brain, but we had some kind of internal endogenous keys that we just didn't even really know about. And that's the anandamide system. So can I have the next slide, please? So what this is a good slide. It's packed with a whole bunch of good things, but we'll kind of get to the comma, I think, if we can. And so what we have here is this space between neurons. It's called the synapse. The pink arrow pointing down, this is pointing down from a neuron, and the signal is going this way, the big signal that we want to talk about, which can be The signal could be dopamine, it could be serotonin, it could be norepinephrine, it could be GABA. These are all chemicals that we think of, and they turn on parts of the brain and they turn off parts of the brain. But what they do is we have a big release of that chemical at the end, and it turns on the next messenger in the pathway to get the message propagating further. The anandamide receptors, the original purpose of these things was to modulate. Okay, so these things were supposed to turn down or modify the signal that was coming at them from the other from the neuron who's sending the stuff. So it's a retrograde signal, and it's a retrograde modifier. My metaphor for this is that what we have is like if we were trying to make a signal, and we picture the person in the singing booth, and we have the recording engineer outside of the glass. Okay, the really important part, the message, is the singer in the booth. Okay, and we want to hear their voice as clearly as we possibly can, and perhaps the other musicians in the booth with them. The cannabinoid receptors are like the mixer board. Okay, we need an expert operating this thing if we want to have that gold record. Even if we have a great singer in there, we need these knobs turned properly. Okay, and so what we need to do is, when there's too much high, we turn the high frequencies down, the gain, and all these different knobs. Okay, and so that's when we're using our anandamide receptor, or when we're using our anandamide system, our internal system. What we have is a professional engineer sitting at the desk and making the sound as perfect as possible, getting that signal to come out true. When we use marijuana, what we have is an amateur who comes and just swipes the whole board and knocks all the things, turns everything up to 11. You may get an interesting sound for a minute, but somebody's got to come who knows what they're doing and get all the knobs back to where they should be. Could I have the next slide, please? Here we have the distribution of cannabinoid receptors within our brain. So we have some in the cerebellum. We have some in this structure right in the middle that looks like a C. They actually say that looks like a seahorse. We see that in the nucleus accumbens, that's this front dot here, that is covered in cannabinoid receptors, and so is the ventral tegmental area. That's the back door, just a little bit behind it. And then what we have up top is a whole bunch of distribution all through the cortex of cannabinoid receptors. Those things are responsible for why this is a pleasurable experience and why anybody does it in the first place. That's what makes it feel kind of funny and feel kind of interesting and giggly. Okay, but you'll also notice that prefrontal cortex is kind of littered with these things too. Okay, have the next slide, please. So we know that what it says is that THC is a lot more powerful at stimulating these receptors than our initial system was. And if we go to the next slide, that's what this is. So in terms of it should be probably backwards. I think the THC is the sledgehammer and the anandamide is the scalpel. And so what we're supposed to have is fine tuning with this system, but or like the guy who comes and just knocks all the mixer board knobs to one side. That's what happens when we bathe our brain in THC. We're just overwhelming the appropriate signal modulation in favor of a more fun temporary experience. The next slide, please. Okay. This is kind of important, very important. Why didn't we get here earlier? But yeah, so we know that with really good data, we can say that there is a significant association between marijuana use in adolescence and all of these things, both anxiety and depression and psychosis, diminished life satisfaction and achievement. And that achievement is measured in career satisfaction as well as income. And there's cognitive decline, and there's substance use disorder. Substance use disorder is kind of the way that we say addiction these days, especially in the clinic. But a lot of the old, slightly older research even will use addiction as that word. So if you hear me say substance use disorder, you can sub addiction in your brain, or I can use both. Next slide, please. So that part that looked like the seahorse, that is this guy here. That is the hippocampus. Okay, that is the area of our brains that's most responsible for laying down memory. And what we see is that in heavy marijuana users, there's a significant impairment in various different kinds of memory. Okay, working memory is one of them. Long-term memory is another. And both of these are impacted negatively in moderate and heavy marijuana smokers. And that has been shown. And it's actually been shown that the volume of their hippocampus, like so the amount of cells that they have occupying that space, is down significantly in cannabis users. Next
Ooh,
slide, please. Um, Yeah, so there, it's very profound, and we know that developing brains are not. This isn't just. It's not just a little marijuana or just a little pot. When kids are just experimenting, we know that if they're, when they're using substances, it is having significant effects that can be very long term. These effects are not for everybody, but we don't know who they're for, and it's not entirely dependent on the dose of marijuana that we use. However, it's a little bit dose dependent. Less is better than more for sure, but we don't know where that safe line is. So it's really hard to say. It's just a little bit of experimentation, and we got to let this go. They're just doing what I did when I was in high school. It's we're not dealing entirely with the same substance as when we were all in high school. It's significantly more potent, but we can get there. Next slide, please. Um, Great. So this is the Dunedin study, or Dunedin. I've not ever pronounced this word properly, and I've said,
Dunedin. My brother
yeah.
lives there.
Oh, perfect. Thank you. Dunedin. Okay,
It's near
perfect.
Tampa in Clearwater, Florida.
No, this is actually Dunedin in New Zealand.
Oh, okay. So he
But
doesn't
same,
live there.
like same named thing, yeah. And so this is this fantastic study that they did, where they looked at a cohort of children who were born in 73, I think, in Dunedin. I got that right? And they were able to they followed these kids in this incredible way, and it's this wonderful source of data that hundreds of papers are written about every year. And what they did was they have some pretty good data that talks about the cognitive effects of marijuana, because they gave these kids IQ tests a whole bunch of the ways through. This is an incredibly expensive study, but it's incredibly valuable in what it's been able to show us. The next slide, please. And so, yeah, tons of points in where they were able to measure the IQ of these people. And most importantly is that they're sort of before initiation of substance use, especially marijuana use. Can I have the next slide, please? And what we see is that this is supposed to be our IQ points, and we're looking at from the IQ that was measured at 13 years of age to the IQ that was measured at 23 years of age or 21 years of age. Okay, and if what we see is that if these people were using no marijuana at all, their IQ went up slightly, very slightly. It sort of stayed the same. Our IQ is actually supposed to stay the same for our whole lives. Our measurements of it get a little better as we go older, but that this is good. This is normal data. It says that the testing that they were doing was appropriate. But we see that even a little bit of use has some decrease in our in the IQ. But if we get to marijuana dependent for 3 years, what we see is a very significant decrease in IQ. There's a whole bunch of different estimates, and this has been reported in a lot of different ways. But in general, 3+ years of marijuana dependence is thought to do a 4 to 6 point reduction in IQ, and that's significant. That's not post-secondary or not necessarily, but it might be PhD versus not going for that. Like that's I wouldn't want to drop that many points, though I may have in my youth. Next page, please. This is another aspect of brain health that we've seen diminished in heavy marijuana users, and this is the part of our brain that connects the two sides. And so this is a high level, important piece of our brain that we don't actually understand very well, but it's called the corpus callosum, and it's significantly thinned in heavy marijuana users. And this is a repeatable data. Can I have the next slide, please? So we get to this sort of important topic, and this is Dr. Levy, my boss, prepared this study. And so what this looked at was adolescents who were using marijuana, and it was moderate and heavy users of marijuana, and what their reports were for psychiatric symptoms. And in addition to some depressive symptoms that were reported, the most important scary things were that between moderate and severe users, 27% reported hallucinations. This includes hallucinations that were when they were acutely intoxicated, but that's not really a normal good thing. Anyways, paranoia and anxiety, but all three of these are during, while they were high or not high. And so that's a pretty significant portion of people who are describing a psychotic symptom. So psychosis, that paranoia, and hallucinations are the most important ones that we would put in the category of psychosis or psychotic symptoms per se. Next slide, please. But I think we've all maybe heard this data, and I remember as it was coming out, there was actually some debate. It's like, does marijuana um, cause psychosis? Does it unmask psychosis that was already there? And there was a lot of debate, but it's actually relatively well settled. When we look at all of the studies that have said the increase in incidence of psychosis associated with marijuana, we see that it's very real. It's not just we're seeing these kids earlier. There is a significant association between marijuana use and psychotic symptoms. And if we go to the next slide, what we see is that when we use like heavy cannabis users have a very significant, this in red, like a 7.4 adjusted odds ratio of or hazard ratio, pardon me, for developing a schizoaffective disorder is incredible. That is a huge amount of risk that heavy users are taking on. It is a lifetime risk, and there can be no debate. This is not good for our brains, and it can develop into, and it can increase the likelihood for developing psychotic disorders. Have the next slide, please. Yeah, so this is actually the last slide. But this is going to leave us some good time to discuss some things. But yeah, so the data is clear. Heavy marijuana use leads to worse psychiatric outcomes, especially when we're talking about psychotic disorders. There's lots of evidence that says that it's worse for our depression and anxiety, despite on a lot of people's medical marijuana cards in states where that's allowed, depression and anxiety being reasons they can get and use medical marijuana. But that's a discussion for another day. So why don't we pause? We can take a whole bunch of questions, and we can even, I can tell you anything you'd like to know.
Thank you. So the first one, I think we covered that it is highly correlated with schizophrenia and psychotic disorders by using drugs. The next one, is there a genetic test for substance abuse disorder? They were reading about it, the GARS.
Okay. I've not heard of the GAR specifically, but so I think that when we know that there's a very strong inherited risk for developing substance use disorder, and I think that now we have specific genes we can point to, and that the GARS is likely one. But in terms of just having that genetic susceptibility doesn't mean that we have substance use disorder, and so truly, like, substance use disorder is a clinical diagnosis. It's you're using substances enough to affect your life in the following ways. And so if those effects aren't there, even if you possess the gene, you've just I don't know, you've been fortunate enough to live in an environment or be healthy enough psychologically and work on yourself enough and learn enough that you have a bunch of different mechanisms for dealing with the uncomfortable emotions in your life, and you haven't turned to repeated substance use. Like, you can carry a gene that could be really have a very high risk associated with it, but not actually have the disorder. So, and I think that what we have is a limited number of genes that are candidates, and we don't have. No, it's useful, but I think that the story is usually there too. Like, there's, in everybody's family, there's somebody if we ask hard enough. But we know families where this is rampant, and it's running through generations.
Okay, another question. Let's see. Are you involved in the ABCD study? Curious if substance use is being studied.
So yeah, it's being. I'm not involved in the ABCD study. We are not involved in the ABCD study. There is lots of research ongoing, like, constantly, and there's some really interesting things. And I think that one of them that might be relevant to what we're all talking about today is that Um, within within the adolescent substance abuse program, um, at Boston Children's, what we saw was that brief interventions can be very effective. So, what that means is that when people go to their physician, their pediatrician or their primary care family doc, whoever it is, if these doctors are asking about substance abuse routinely, they're screening and they're asking the right questions. And sometimes the screening that we can do, we've actually whittled it down to 2 questions. Okay. Do you use any drugs? And how many times, or when was the last time you had more than 3 drinks? And if there's a positive on that, what that leads to is a further investigation or a further interview about substance use, and then a brief intervention. So what it does is we screen, and then we ask a little bit more pointed questions if they screen positive, and then we do a brief intervention. The brief intervention can be, here are the safe drinking guidelines for somebody your age. It can be simple as, we recommend no cannabis use until at least the age of 25 due to your ongoing developing brain. And we know that these little brief interventions, because of research done at Boston Children, are actually effective at shooting people down the risk ladder. Okay.
Mhm.
So, if you think of substance use risk as a big pyramid, so there's people who are not using, they're at the very foundation of the pyramid and they have no risk. But then there's people who are using very moderately. And then they're at low risk. And then there's moderate and high risk. And that's the peak of the pyramid. But anywhere we are on that pyramid, if somebody screens, asks questions, and does a brief intervention, it's meaningful at pushing you down a layer. Okay, not everybody all the time, but we see that we are shifting things down. And with a problem like substance abuse, where so many people use substances, where is it a problem? We kind of have to be looking at the whole pyramid and trying to push everybody down further and trying to get everybody into that bottom rung as much as possible. And there's good research to show that with simple interventions like asking questions and giving advice, we do that. Uh, yeah.
Okay, so here's a question. Did you say this is a lifetime risk about cannabis use and increased of developing a schizoaffective disorder or psychotic disorder, or that heavy use of cannabis at any time in your life still raises your risk for schizoaffective disorder or psychotic disorders?
So we know that there is an increased lifetime risk. Most of that risk appears fairly acutely. So what that means is that if people use marijuana heavily for a period of time in their life, most of the time, if they're going to develop a psychotic symptom or a risk of psychosis or schizoaffective disorder, it's going to happen sort of in the next window. So it can be 6 months to 5 years. And if the use calms down, that window sort of closes. It's still there and it's not fully closed. And none of us actually have a zero risk of developing a schizoaffective disorder in the next couple of days. Like we were all a little bit susceptible. And so that lifetime risk is changed significantly, but not dangerously. But you can get out of the woods for that, is what I'm trying to say. But
Mhm.
it's a very real risk that sticks around in a meaningful way.
Another one is, for a person who already has schizoaffective disease, to the best of your knowledge, does using marijuana further their symptomatology, or does it not matter since they already have the disease, or perhaps even improves their quality of life through its sedative and perhaps other effects of THC?
So that's a really good question. I think that when we talk about populations and we talk about substance use in the population of people who have schizoaffective disorder, in general, it's a bad thing. In general, it's a major problem. They're very highly associated with each other, and the marijuana that people are using these days has such high concentrations of THC, and that high concentration of THC is responsible for the euphoric and hallucinatory properties of the marijuana. So when you have a brain that is kind of primed for hallucinations and maybe having them on its own in some delusions, and we add a chemical that heightens that, typically people with schizoaffective disorders who are using marijuana are having more positive symptoms, like the positive symptoms being the voices, the uh, fearsome paranoia, the delusions of persecution, the delusions of grandeur, all of these sort of positive things. The negative symptoms are sort of that flat affect and the other parts of schizoaffective disorders that we think about. But we know that marijuana specifically makes these worse. It's interesting because things that like dopamine and the dopamine pathway in the reward area and in other areas of the brain is largely related to schizoaffective disorders. And so stimulant use, like uh, cocaine, specifically crack and methamphetamine, is really big in the schizoaffective disorder. And it may be from seeking to self-medicate on some level. And there is some improvement in the feeling inside when pardon me, people with schizoaffective disorders, brains are sort of awash with a little bit of extra dopamine because they have an imbalance. Doesn't mean it makes them better, but they're driven towards doing it because they feel a little better on some level. I don't know if it translates. Well, we know that it does not translate to function. However, what you said, like maybe there's somebody out there who a little bit of marijuana use helps their schizoaffective disorder. I'm not going to say that that's not impossible. And I think that on an individual level, things could be considered that on a population level, we would say not a great idea, but willing to make exceptions.
So I think this is a no-brainer. So now the nation seems to be slowly but surely going to that recreational use. And I think the issue is, how do you keep marijuana out of the hands of those under 25? How do you, but it's the same with drinking. I mean, when kids drink when they're in high school and college, a lot of them tend to binge drink. They don't have a glass of wine and go home.
Yes.
Yeah.
Yeah, it's there's I think that an important thing to think about, or a couple of things, is that I think that adolescents listen to the messaging and they listen to the marketing.
Mm-hmm.
And these things get through in a very big and important way. And so is it possible? Can I share my screen? Is that
Yes.
possible? Okay.
Stop share.
Oops. Let me see. Let me just get my right window up here. Okay. Oops. Screech it. There we go. This guy.
Okay,
Sorry,
we can
bear
see
with
it.
me. Okay, there we go. This probably isn't the one I want, but it's close to it. Okay. This is from the Monitoring the Future study. This is a sort of recurrent study that happens every several years, 2 or 3 years. And it's of high schools across the United States in all 4 regions, looking at surveys in 8th, 10th, and 12th grades. And so this is data about marijuana use. And we see there's a very slight increase in marijuana use over the last 3 years of the survey. We don't have 2020 data yet. If it's like everything else in 2020, it'll be bad news. But yeah.
True.
But so that's what we see. But if we look at things like this is the important slide that I wanted to get to. When I said kids listen to the messaging around opiates and the dangers of opioids has been very effective, and kids have heard this message, and the use is down. There was a lot of experimenting happening when that was wild, but it's going down, which is a positive thing to think of, I think. As well as stimulant abuse. And perhaps some of this has to do with better prescribing practices, but I think that some of it has to be attributed to the good public health and public awareness campaigns around some of these substances. They listen to the marketing too. And what we saw was that cigarettes, like cigarette use is bottoming out. It actually took 30 years of anti-smoking campaigns to get cigarette use at a really good level that was under control. And since Juul came out, 4 years of good marketing decreased, totally wiped out 30 years of public health campaign. And so what I'm saying is that, like, when we get good messages out, we see that there's change in adolescents' behavior. And when there's really effective marketing, we see change in adolescent behavior. And I think that binge drinking It's hard because it's part of college culture. I think that in order to try to try to change that pattern in late adolescence and even in high schoolers, there has to be a cultural change. So how do we
Mhm.
get that message to them? I have no idea, but when I figure it out, I'll let you know.
Mhm.
Yeah.
And we had a couple, let's see, a theory mentioned in a great course on the addicted brain was that people susceptible to addiction may be due to a stunted usual response in the pleasure center of the brain, which makes substances so much more appealing when everyday rewards are not as pleasurable. Have you heard of that?
Yes, it's interesting, and the data is a bit conflicted, and so there's some studies that say that people who are susceptible to addiction, depending on the stimulus that we're using, may have a bit of a blunted response. And there's other data that says there's an enhanced response. And so it's tough because I don't know if we know. I think that I think that I think that we know something's going on with their dopamine, and maybe both are actually true. And to certain stimuluses, they are blunted, and to certain stimuluses, they are, quite sensitive. And so, maybe that's. I don't know that we have data to take that like hypothesis into a practical theory, but I think it's very interesting and very real. I think it's true.
Okay, and then let's see, focus on risk factor. So if marijuana can cause psychosis and trigger schizophrenia, can stopping marijuana use reverse those symptoms and lead to recovery from schizophrenic symptoms?
Yes and no. Yeah, largely. So schizophrenia and schizoaffective disorders, like everything else in psychiatry and medicine, it's a spectrum now. And so, depending on where we are on the spectrum and depending on how much of it is substance related, taking away that substance may take us from a diagnosable schizoaffective disorder back to a normal state of health or mental health. But some people, they may improve and their symptoms may improve, but they still may remain diagnostic. So depending on where we are on that sliding scale, I think that's the answer is it's certainly going to improve because anything that's going to be causing psychotic symptoms, if we take that away, we're going to have less psychotic symptoms. We just may not have none.
Do you think it's related to the age they start using? So if they're 14 and they start heavy marijuana, and maybe they had a pre-existing genetic or heredity factor, will their outcome be different than if they started heavy marijuana use at 18?
Yes. In almost every outcome that we could measure, in terms of their likelihood of developing a schizoaffective disorder, that goes up. Their possibility to developing cannabis use disorder or other use disorders goes up the earlier that we initiate. So
Yeah.
early initiation is a big risk factor. When we see kids in the clinic who started, they smoked their first joint in grade 6, those get me a lot more frightened than the kids who, the freshman year got my
Yeah.
Juul and I got my vape
Yeah.
pen. Those kids, I'm not worried about them, but that's a normal story that I hear. It's the kids before that peak my alarm goes off. Yeah.
Okay, well, we don't want to overstay our time. If you could, it'd be great if you could send me that other study, the NIH study that has all of the cool
Oh, sure. The
slides.
the graphics. Yeah,
Yeah,
yeah, I can
and
get you
I'll
that.
I'll share that also, but we want to thank you. This has been wonderful, educational. I think that if we want to pass legislation to make marijuana legal or recreational, we should have a tax that is set aside for treatment of psychiatric disorders
Yeah.
or research, you know.
Absolutely. Like I'm pretty conflicted myself about the legal status, and in the country that I'm in, it's legal now. I it's tough, and the data that's coming out, it's mostly U.S. data, where state by state there was some legal for recreational, legal for marijuana use or medical use, and there was sort of some nice comparators that were saying that we weren't seeing a ton of use go up in the adolescent group, which made me happy. But that remains to be seen, and it remains to be seen how the culture shifts. I think that, sometimes prohibition of these substances, there is some taxable income there, and when they're prohibited, that doesn't mean that there's no use. And I think the wrong people are getting rich when that happens. It might be nice
Yeah.
if we put that money into treatment. I think you're right about that. Like, maybe there's a mature way to bring these things into the fold.
Well,
But
thank you again. I know it's getting late where you are, and I'm sure dark and cold. Um,
it's
well,
it's
we
all
was,
of those
yeah,
things. But thank you
yeah.
so much. And if people have specific questions, I'm happy. Like, you can
I'll
send me an
I'll
email.
compile them.
I'll take an
Yeah,
hour or so and write things back. Okay. But thank you guys so
yeah.
much for your attention. I really
Thank you,
appreciate it.
Dr. Kelly.
And
Thank you.
I hope you guys have a great rest of your evening.
You too.
Thank you. And we'll
Okay.
post the webinar and slides up as a PDF on our site in the next few days. We have a ton of people that were still at work because it's still early here. Thank you
Okay.
very much.
My
Have a
pleasure. Have
great
a great
evening.
evening.
Thank
Thanks, you
you.
too.